Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Medication Safety Challenge Are You Up For It conference call. All lines have been placed on listen-only mode, and the floor will be open for your questions following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Cindy Warner. Cindy, the floor is yours.
Thank you very much, Erin. I'd like to welcome everyone to this wonderful webinar that we're about to engage in. We have some terrific information to pass on to you. I did want to make an announcement. We did have quite a few registrants at the last hour, so if you are with anyone that is having a delay or a busy signal with signing on, we thank you for your patience, and we're addressing it as best we can. So that being said, let's go ahead and get started. First, I'd like to welcome you on behalf of VHQC, and I am extremely excited about kicking off this first webinar. This is the first of a 5-part series that will finish up about this time in 2016. So let's go ahead and get started. We want you to get the most out of this webinar, and here are a few tips to help out. I know some of these suggestions might seem simple, but I would like to challenge you to try it out, and that way you'll be able to get the most out of the session. And it looks like my slides are going a little bit quicker than I want them. Here we go. That I'm not going. I'd like to, at this point, thank and acknowledge the Virginia Pharmacists Association for partnering with VHQC for the processing of the continuing education credits for the pharmacist participants. We will have a recorded webinar with the opportunity for continuing education credits. Those that choose to view the recorded webinar will have a SurveyMonkey questionnaire that must be completed in order to receive your credits. All of the webinar series, the next 4 sessions including, will offer CE credit, and I will provide more information regarding the CE credit at the end of the session. And then now I would like to just briefly share some information about VHQC before we turn the handball over to the speaker. VHQC is the Medicare Quality Innovation Network Quality Improvement Organization for Maryland and Virginia. We facilitate numerous quality improvement projects in order to improve care and services for Medicare beneficiaries. We engage providers and partners at all levels of the performance for collaborative learning and action. Our work supports activities at the local level so that providers and partners can learn from each other, use data to drive improvement, and help those they serve to achieve better health care and experience lower costs. The focus in the VHQC care transitions and medication safety work is to improve care transitions, decrease adverse drug events, which will hopefully also decrease hospital readmissions. Our focus today is medication safety, which crosses all areas of practice and care transitions. Today's webinar is the first in a series, as I've mentioned before, that will continue through 2016. And on now to the most important part of this session. It is now my pleasure to introduce today's esteemed presenter. As you can see, she is at the helm of coordinating and providing leadership for public health service pharmacy programs. She has also served and held leadership positions in the Indian Health Services, Veterans Administration, and currently at CMS. Not only has she obtained degrees in biological sciences, a PharmD, a board-certified ambulatory care pharmacist, but she is currently working towards an Executive Master of Health Administration. She has received numerous awards and recognition for her leadership and excellence. In working with her in preparation for this webinar, I have had the privilege and honor to be personally exposed to her commitment, enthusiasm, and dedication to both pharmacy and improving medication safety and public health. She has been an inspiration to me, and I know she will inspire all of you today. It is with great pleasure that I hand the program over to Rear Admiral Schweitzer at this time.
Thank you. So we want to hand the ball, or there we go. Very good. Let me click on that. Okay, very good. Thank you so much, and it's really quite an honor for me to be here today and really be able to have an opportunity to provide input and speak on medication safety, a great topic for all of us. And I want to thank Cindy Warner, VHQC, and the Virginia Pharmacists Association for putting on this important program, very timely. I came from a family of pharmacists. My dad was a pharmacist, I had uncles that were pharmacists, and my grandfather was a pharmacist. And I remember him growing up when I was a little kid, going to his pharmacy on the corner there in East LA. It was a community pharmacy, and I'd visit with him, and I'd be able to sit at the counter there, and not him, but one of his staff would make a malt or ice cream for us, and we would be able to read the comic books, and I had a wonderful time just sitting and watching him, and people would come in, and everybody would say hello to him, and he knew everybody, and they'd come ask him a question, and they'd go, "Hey, Doc, I have a question for you," and he'd go help them out. And so that inspired me a lot over the course of my just career, knowing that those relationships and communicating and connecting with people is such an important part that we need to make sure we don't lose that, because that's what makes pharmacists so invaluable. And I'll talk a little bit about that later on. So as pharmacists, as healthcare professionals, we became part of this really great profession because we wanted to help people. And one way is to really help them navigate through this healthcare system, to help them with their medications, and just be sort of like the point person for them in the healthcare system. And a lot has changed in the recent years, and a lot has changed, and we may think, oh no, it's not great, but there's actually a lot of really great opportunities right now that are available for all of us as we're undergoing this changes in the healthcare delivery. Pharmacists play a critical role in reducing adverse drug events, improving patient safety, and because we're so accessible as healthcare providers, we're among the best trained that are out in the communities to help patients with their medication. It's going to take a different kind of collaboration with other healthcare professionals to implement the changes and the improvements that really need to be made to improve quality, safety, and reduce healthcare costs, especially related to medications and the healthcare system. So today, as you're listening to all this, I hope that you can take away at least one. Notice I only said one because we want to make sure everybody can do one. Incorporate an idea, something that you can incorporate into your practice setting, or just maybe an idea that resonates with you that, hey, I want to look more into that. Hey, this is something that I can do. So I challenge you right now to be, as you're listening to this, to think about things that you might be able to do. And I'm going to give you lots of ideas, so I'm hoping that you'll pick one of them. So medication safety, it's a broad and complicated topic that has just a whole bunch of different facets. So there's a lot of science and data now on this topic. And some of over the course of this next few minutes or next hour, I'll be sharing some of my own experiences. And ultimately, this whole topic has become really a national issue for several reasons. So anyway, I will go on to the next slide. And I put the objectives here. Oops, these are the objectives. And what I wanted to do is I tended to focus not on the prescription filling process so much, but as you know, it's a comprehensive, the whole idea of medication safety is a comprehensive overall big picture. So I focused on areas that will help solve the system problems. So on to the next one. You can see all that. And before I kind of get started, what I wanted to do is take a few minutes and just talk about the U.S. Public Health Service Commission Corps, because that's what I'm part of. And we serve under the Surgeon General, and we kind of are spread out. There's a little over 1,200 of us, and we're spread out throughout the nation in different health and human service agencies and other agencies too. And I listed down there some of our initiatives that we're focusing on, curbing tobacco use. These are initiatives that all of us are focusing on, all the Commission Corps officers, and there's a total of 6,700 of us throughout the Commission Corps, and we're part of like other disciplines of physicians and nurses, We have dentists, veterinarians, engineers, across the board. There's a lot of different disciplines, and then pharmacists were one part of that. So we're really making an effort, the pharmacists are, to reach out and actually connect with all the different, the whole pharmacy profession. And so I'm hoping that you see us more visible because we're trying to make an effort to get out and be more visible. And you'll notice, so I just wanted to do a little plug for that. You'll notice, I'm going on to the next slide, which is why focus on medication. And you'll notice on most of the slides that I have, I put references down in there if you want to read more information on it. Unfortunately, some of these topics we can talk like the whole hour just on that one topic. And I just wanted to highlight so to give you a little taste of some of the information that is out there. So the next one is here is why focus on medication. So this is a really good question, and what has happened is, and this has sort of come to light now because we realize now that medication has become way more complicated. There's a larger number of medications, and they come in all different formulations. There's different routes and actions and names, and even though we have treatments have improved over the years for chronic diseases, we now have patients that have many comorbidities, and they take a lot of medications, and this increases the risk of drug interactions, side effects, mistakes, and also the delivery of medications involves just so many more healthcare professionals and caregivers, and patients get their medications from more than one place, and it's just a lot more complicated just overall. And we can see here that how easy it is to have a medication-related issue just because of how complex all of the system is now. I wanted to just level set and just mention a couple of the definitions here before, especially for the next slide. And the main one I want to talk about right now is the adverse drug event, because an adverse drug event down there could be preventable, but it also may not be preventable. So it's an event where medication or an adverse drug event may be preventable, like it might be an error, or it may not be preventable. In other words, it might be an allergic reaction. So just to give you an example, and I'm not asking the question out, you don't have to respond in chat or anything, but like we have friends in our family, and we had an elderly friend of our family, and she came over, she was like 85 years old, and she had a slew of medications that she was on, different bottles. And we weren't paying attention to it so much, but we went out for a walk, and it was on a little trail, a little bit uneven, and she fell down. Well, we went back, and we were worried. Nothing happened to her, luckily, but we went back and sat down with her medications, because it just occurred to me, since I'm a pharmacist, well, maybe, there's something with her medications, because she's elderly and she's on medications. So as I went through her medications, I was asking her how she takes each one of them, and I found out she only took all her medicines when she felt, when she thought she needed them, but only one was she taking on a regular basis. And that one she was taking on a medication she said was her heart medication. And when she showed me the bottle, it was actually a benzodiazepine. So that's the one she thought was her heart medication. And the reason why I'm saying this is because one of the suggestions that I've heard many times, there's committees on this, I'm not sure if any of you are on this, at a national level, is to encourage the prescribers and encourage the healthcare profession to include the indication on the bottle. She was not aware that was not her heart medication. She thought that bottle was her heart medication. She was not aware it wasn't. So we had to get all that straightened out and get that fixed. And the concerning part is she was in a family that did not have anybody in the medical background in her family. Her kids were not, and anybody else in her family was not. It just happened she happened to be at our house. And I have a brother that's a physician. We have a whole family of medical folks, and we were able to help out. So you can imagine that's one person, and there's so many people out there that just don't have anybody to help them sort through that information. So the one plug I'm going to talk about it a little bit later, is just finding a way to add the indication to the label, so at least that will help patients being able to know what their medication is for. And I'll talk a little bit about how to do that in a little bit. And I'm going to go on to the next one. Okay. For the next several slides here, and I mentioned a lot about, there's a lot of data and a lot of information. The next several slides are really meant to share with you the impact, and I'm going to say the reason why this whole topic has so much attention now. And a lot of it has to do because the prevalence and the increase and the realization that medications play such an important part in everybody's managing whatever their disease states or managing just health. So 82% of American adults now take at least one medication, and almost 30% take 5 or more. That is a lot. And at least 40% of the cost of ambulatory care adverse events are actually estimated to be preventable. So with all this, as they get more data, we have a lot more data now. That's why they're able to come up with these numbers and extrapolate things, and they know costs. The coding is improved. So we're able to get this data, and that's why this is all such an elevated issue. So there's a lot of money being spent. And that's really what you need to take out of these slides. There's a lot of money being spent. There's a lot of room for improvement. But this is also opportunities for us, because as I tell folks when I go out and about, when you go visit people and go to talk to a physician, if a patient were to bring in a pile of medications, those are very complicated to sort out, to figure out what is the right group of medications for this patient. But for pharmacists, this is something we do all the time, and it should not be, this would be an opportunity for us to help optimize people's medication. So the other number is between 33 and 69% of all medication-related hospital admissions are due to non-adherence. And that's a big number, too. When we say non-adherence, a lot of this can be related to just not being on the right dose or not running out of their medication and not taking it, and also having to go to the emergency room. And let me see here. And then the other one I wanted to share here, too, was with this is related to emergency room visits, and this is 59% of the patients that come to the drug-related emergency room visits are preventable. And you can look here, and this is the percentages of what they're broken down to. So adverse reactions, non-adherence, wrong or suboptimal doses. So you can just see there's plenty of data on this, and people realize that this is a problem. So the question is, how do we insert ourselves into the system to be able to help this? Because the data is out there. It's what we need to do is really get at the table to be able to help make a difference here, which we can do. And things are changing. We're going to be able to do this better. All right, I wanted to talk a little bit now about medication use. And I know future presentations are going to talk a little bit more about the steps in the process, but I wanted to talk different on these steps in the process. So first of all, what we want to do is, we all know that in using medications, there's prescribing, dispensing, administering, and monitoring. Those are all broken down, all the pieces involved in using medication. And we may think that, oh, that's not on our part, prescribing. But actually, you know what? We have a role in every single one of these. And that's what I want to try to emphasize. And that's how the whole system is changing right now, because we can't do this. Nobody can do this by themselves. The prescribers can't. The caregivers, nobody can. This is actually more of a team effort, and we need to figure out ways to communicate and coordinate all this care. So to give examples here, so on the prescribing piece, so things that need to be considered, and this is something that the pharmacist may know, especially if you know your patients real well, and they come in and the patient calls you their pharmacist. So just the prescriber may not always know, because their visits are super fast. They don't have to, they don't have time to get all the history down, or the patient doesn't have time to even relay it all, or they don't think of it at the time. So just to consider physical, cognitive, emotional, and social factors that would alter it or change it. Things like comorbidities, health literacy. just other medications that patients may be on that the pharmacist knows about that the prescriber doesn't, because they don't always have the full picture, the full story of it. I can tell you that when patients come in, and I worked in a pharmacy for a long time, really busy pharmacies where, we had 1,000 prescriptions a day. And what would happen is I'd be working there, and I was a pharmacy director. So some days I would have a day where it was just like really busy, but it would always make me happy to go and just start, counseling the patients, spending time talking to the patients. So I would call in the patient we had counseling rooms, and we'd bring them in, and they'd bring out the medicine into them, and just ask them to tell me, how'd your visit go today? And they would tell me about the visit, and we'd kind of go through all the medications. And there was about at least, I would say 90%, maybe even higher, of the time I was able to make some kind of intervention. The patients would talk freely. They would have questions. They weren't sure about something the doctor said. I might have to go get clarification, but they went through, they were able to, we were able to go through the whole visit, so they had a plan. They might have had family members in with them to help go over with them too. They didn't have a family member in with the doctor, so we could get clarification. So what it really showed me is that how much patients really have a lot of questions. And even any of us, if we take one of our family members to see a doctor, whether it be our children or our parents or a spouse, we always know there's a little discussion afterwards because to make sure we understood correctly what the instructions are, what we're supposed to do, and what the plan is. So you can just imagine if somebody doesn't have anybody in their family that they're going to be confused about that. So seeing that example there, and then just observing and watching, just how some of the pharmacies and how they are when patients come up, sometimes I'll sit, it's like I'm waiting for something, I'll sit and watch just all the interaction. People, you can tell that they aren't comfortable, and there's data behind this too. You also may have observed this, but you also know that there's data behind it, just so you know, that people aren't always comfortable when there's a line of people right behind them to ask the questions and to say the questions or just answer questions that they normally would be if there wasn't a counseling room available. So if you have opportunities to have a counseling room, or if you have a closet or something nearby that you need to clean out or get ready, just want to let you know people talk a lot more open. They're a lot more free. They share a lot more, and then also you're going to get more information. You're going to be able to help them better if you have a place that's a little bit easier or quiet or separate from the people in line at the pharmacy. I know for me, I don't even like sharing my phone number. When I go up and they ask your phone number or they ask your date of birth, I don't like saying it too loud either because there's someone right behind it. I don't like giving all that information out. So you know what I'm talking about. It's just that people are a lot more comfortable when they can be in a secure setting, sharing information about things. And I mention this because when we were in a hurry, let's say I had a busy day and we were in a hurry, we wanted to move patients, we wanted not to make the wait very long, we would just go up and you would call the patient up and you would say, okay, here's your medication, go through everything real quick and just say, do you have any questions? And they could tell when you're busy, they almost always said no. So those same group of people, if I bring them in a room, they're going to be more open. They do have questions, but they're not going to say that when there's a line or if they've been waiting long or we seem like we're in a hurry. We, the pharmacists, seem like we're in a hurry. So I wanted to mention that. The other area here is just dispensing. I guess that's kind of straightforward, but some of the things that are challenging for us that we need to all work on are just when we're in these high volume, high workload areas, there's a lot of prescriptions, having all the distractions and giving that patient the full attention that they would feel most comfortable communicating with you. And then also reducing all the stress. It's pretty busy in those pharmacies. Sometimes the workload looks really busy. The other area is administering. And I know that sometimes it's easy to have a handout and say, here's how you use this device, or here's how you use this medicine, and in the hope that they know how to do it. But I can tell you that most of these items where the instructions, putting things together can be complicated, then they need to really have help doing this. And this is also where they need to sit down and go through it. And you may need to go through it more than once. I know for a fact that inhalers, people do them. There's data behind all of this too, that they don't just learn it after one time. It takes repetitive over and over again to make sure that they're using inhalers correctly. So if they're not using it correctly, then these are the areas where they potentially, if they're not using it correctly, then they would get an ER visit because they are suboptimum dose or overdosing or something like that. And then the other area is in the area of monitoring. And these are things, and I'm just going to put out some examples here. These are areas where we would want to monitor for side effects and stopping medication. How many patients do we know that come in and they get a prescription filled, and then you talk to them, and a few days later, they may not even be taking the medicine. They took it a couple doses, and they didn't like the side effects, and they just stopped taking it. Or they weren't clear, they stopped taking it, they don't realize it after they finished with their refills, and they don't know they're supposed to continue taking it. So wouldn't it be great if after we had a service, and you would call the patient up, and not you or somebody in your staff would call the patient up or contact the patient, however you want to contact them, and just see how they're doing after they started a new drug, and to see if how it's working. If there's problems, you can get those corrected right away. So these are like services that we want to try to catch and help patients take their medications, and if they don't have anybody to talk to, or they don't that's easy to talk to or quick to talk to, these are areas where we can actually make a difference. So I know that when I was back when I was a pharmacy student, I had the opportunity to go on a rotation that actually made a big impact with me. I got to go to patients' homes, and I was with the nurses, and I got to go watch them, how they interacted with the patients, and saw how the patients all organized their medication. And it was all types of patients. And it was pretty surprising and eye-opening to me because I was used to my house and how we organized medication. And remember, I had a father who was a pharmacist, so we were probably doing everything the correct way. And then later on, I saw people had all different ways of doing it. Later on, when I worked on the Indian Reservation, we actually worked with the public health nurses and would sometimes go out with them on the more complicated patients, but we also would communicate with them because they would be out in the field. We would work with them. In other places, I worked with community health workers, and these were had a little bit of training, but they were really people in the community that would go out, and they would reach out, and they actually were very familiar with their communities, and they could help with some of the language issues, and then just they knew everybody, like all the neighbors and everything. So that's why we ended up using them. And we went and asked them, well, how can we help you? Because you're following up, you're sort of extenders of us. And what they wanted to know more than anything was how we could, a little bit more about medications and how we could train them so that they can help people with their medications and go to their houses and help them put them in the pill boxes or whatever they were doing. But they could help them because they were in the community there, and that was their job and role, and that's what they were getting paid for. So people had questions like, what do I do with these old medications, and how do we they just had general questions, and we could help with them. So we provided a lot of training for the folks in the community in those particular settings that we were working in, and that was really, really helpful. So I'm not sure if each of you in your setting, you sort of know how your practice setting works. These are things where you can reach out to people that are providing care already in the community, and there's different groups and different organizations, and just offering to figure out, is there a role, is there any help that they need with medications, is there some information you can provide, and just develop those relationships in your community. And that's what we really want, is the pharmacist to be integrated in the community. So the more you reach out in the community to help, you're going to help solve a lot of these problems and issues that come up, because we can't do it alone. We need people, the whole community involved. We need to be extended out in the community. So next, I'm going to go on to the next slide. I wanted to mention what I wanted to mention here is this opioid epidemic. I just have one slide on this because I wanted to highlight that this has been getting a lot of attention lately. You've probably seen it in the news. It's from the White House, from HHS, from our Surgeon General. We're all talking about it, and it's an issue. There's a lot of data on this, but I'll tell you what the tough part is that this is something that has really skyrocketed in the last 20 years. If you look at this, the age group, and this is prescription opioid overdose deaths, it's really this middle-age group here. And if you talk to the health plans, if you were to talk to them, or people that have the data, they can almost predict the people that are going to have problems with this. And guess who would probably know first of all of this? And that's us. That's the pharmacist, because a lot of it, the precursors to this, if they're on benzodiazepines, and they start getting on opioids, they're going to be at risk for this. So I wanted to mention, because this is an area here, and you're probably thinking, well, how can I control this? Because I'm just filling the prescriptions. But really what it's going to be, it's a whole healthcare team. It's all of us together. So this is an area or a topic of discussion. I'm going to talk about it a little bit later that you might want to visit with the physicians. And I'm not talking on the phone and calling and telling them about a particular prescription, but just the physicians groups that you work with in your community, in your area, you know, as you're going to get to know them, because we're going to talk about this a little bit later, you know, this is a topic you can bring up to them. At what point, you sort of are seeing this, and at what point do we need to start being concerned about it? Because you know they're going to be at risk when they get to a certain use of these medications. So I wanted to bring that up. And it's directly related to the sales. The sales have gone up, and it's only been in the last 20 years. I wanted to also talk a little bit about the economics of healthcare quality. And we talk about, we want to keep it prevented admission. We want to prevent death. We want to prevent emergency room visits. Those are all saving money directly. But there's also some other costs that are actually more significant, too, because there's costs to the community. There's also costs just from the family member if something happens not working, to the businesses. So this is the economics of all these health-related issues. And actually, when quality care is affected, it actually affects a lot more than just directly the medical cost. And that's what I wanted to make sure you guys, making sure everybody was aware of. So it's more than we think it is. All right, so now we're going to get to kind of more like positive things here. We talk about this a lot, and I like to bring this up a lot because this is about the definition of health. And I mention this because we talk about health all the time. We talk about, lowering the blood pressure. We talk about hitting a certain metric in diabetes or hemoglobin A1C. We talk about lab values. And we talk about things like that, but really what we want to do is we want to think about health a little bit differently. We want to think about it, it's the state of complete physical, mental, and social well-being, and not just the absence of disease or infirmity. And the reason why I mention this, if you talk to patients, really, and I've been doing this lately too, is what does it mean to be healthy? What does it mean to have health? And for them, it's really being able to do things that they want to do. So it might be gardening. It might be going for a walk. It might be being able to go on play tennis. It might be being able to play with your grandchildren or attend an event with your family. But whatever it is, it's being able to do something, and it's not having to remember to take the medications. They have to eat meals at a certain time because that's when they have to take their medicine. They have to go this day to the doctor. They have to go this day to go get a test done, and where they're living their life all around their having to get their medical care. So a lot of that is one of the reasons why you're seeing so much information technology, and you're seeing all these creative ways of managing care different than we always used to before, because it's hard to be compliant when we have to always be on the road somewhere and drive somewhere and make a visit somewhere. So anyway, I just wanted you to keep that in mind, that really some of this is, and that's why you're seeing some of the changes. And I mention this too because everybody's sort of seen the change now, or they're not everybody, but they're moving that direction. They're seeing that change now. So what's happening is, like for instance, if we were going to optimize somebody's medication and change it so they can take everything once a day, the cost of their therapy may go up. But if that keeps them out of the hospital, if it keeps them the emergency room visit, if it helps that, and if it helps them to be compliant, then we've actually decreased the cost overall. So those silos, the way we manage patients, the silos are decreasing. You're seeing less of that. So let's talk about the pharmacist. There's this article, white paper, came out last week, and I thought I'd share the link to that. You can download that, but I would really read this if I were you. It's a really good summary of pharmacists and their role, and it actually talks quite a bit about the reimbursement of pharmacy services and the direction that it's going. So I thought you would want to see that now because it's kind of timely because we're moving in a direction and pharmacists are getting a lot of attention, which is really great. So the demand, this is numbers that you probably are aware of already, but the demand for primary care physicians is going to be increasing, but the supply is not going to be there. So we know this. Everybody knows this, and this is a little bit nerve-wracking for everybody. And so what we need to do is pharmacists have a good role on this. So community pharmacists are the most accessible healthcare practitioners, with 93% of them living within 5 miles of a community pharmacy. So Americans live within 5 miles of a community pharmacy. So that's what we've been marketing. Everybody's been marketing it. Your pharmacy organizations have been pushing this. And so this is a really great opportunity for all of us right now to be out there. All right, so I wanted to put this up right now. This is, there's going to be a little chat piece coming up in two because I'm hoping, if you're listening here, I'm putting this up right now. These are clinical services right now that are being reimbursed somewhere, whether it be in your state, whether it be in your particular pharmacy. It's somewhere in the United States. These are services that are being reimbursed somewhere. So if you can, let me check and see if the chat question came up. Well, it's going to come up. You're going to see a chat question come up here in a minute about that. Anyway, if you can answer back, just share what services you have, that would be really great. But what I wanted to do is talk a little bit about getting services started. So I've been doing this a long time. So 30 years ago, this is terrible because it's dating me, I remember doing an ambulatory care residency, and what they were doing is, this is early on when we were getting started with ambulatory care, they put me into this clinic. And I was embedded into the clinic, that's the term that they used. And what I was supposed to do was get something started. And when I first showed up, the physician that was there, the nursing, the whole team was there, and they go, so what do you do? They didn't know what I did. So at first, I wasn't sure what to do. So, we talked to them, and I found out finally there was a need. So patients came in, all the patients that came in that had complicated medication regimens, I was going to sort through them first. I was going to take and review all their medications, sort everything out, and come up with a game plan. So this didn't happen overnight. I was only there half a day every day in the afternoons. And so I wasn't able to there full time. I was just there part time. But over the course of a few months, they got to know what I knew, and they had a respect for me. I was able to kind of sort through, help out with formulary issues. I was helped out with a lot. And before long, they were coming to me for everything. And before long, they wanted someone in there full time. And that same model, just starting out and then starting to grow it, happened over and over and over again. And I spent a good part of my career getting lots of different clinics started. So I was just going to say, at first, they didn't know what I was supposed to do, and I sort of just kind of showed them and interacted with them. Later on, I went to another facility, and I had the same challenges. I didn't have any money, didn't have any budget, and I for those services. How do you do this when you don't have that? So what I ended up doing was I found a little bit of extra money, and I only had enough for a half a day once a week. And so what we decided to do was I would have a person come. She was a good clinical pharmacist, someone that interacted well with the physicians. It couldn't be me because I was busy running a pharmacy. So I hired her, and her job was to go meet with the physicians. I didn't have time to even go talk to them. Just start, I call it planting seeds. Start visiting with them, talking with them about what a pharmacist can do, talking about the services that we had and what services would they like. So just really starting a conversation and starting to meet with them on a regular basis. It didn't have to be every week, obviously, because there were too many of them, but just work it all in over the course of 6 months and go visit with them. And then the other thing was to put together a business plan, so how we can justify a position, how we can pay for this, and do all of that. So the reason why I tell all of this to you, because those of you that are in Virginia have a great opportunity right now coming down the pipeline, and so you need to think about, how do I do a business plan? How can I put this together? And what services can I provide? What are the services in my community that in my immediate community? What do the providers want? What kind of services do they want? So anyway, I just wanted to kind of plant that seed because that's how you get started. So before long, I'll kind of finish the story here. We got it started planting those seeds with the providers. We found the providers that really wanted pharmacists. And we started providing those services. It just takes breaking in, getting your foot in the door, and I just do what they want in the beginning, because then it grows and grows and grows. Then you go, oh, by the way, I can do this too. Oh, okay, great. So that's how you get your foot in the door. And a lot of it, the easy, I call it low-hanging fruit, is taking their complicated patients and sorting through all of those medications that they have. They love for us to take that. Those are really difficult and challenging for them, and coming up with cleaning that up and doing the legwork behind to get those cleaned up. You don't just give a list back to the provider, because they may have only take care of those 4 medicines, and there's another provider that takes another set, so you have to coordinate all of that. It's a lot of work, but once you break in, it actually goes a lot easier in the end once they start working with you. So anyway, I will go on to the next one. We started lots of clinics, and some of the clinics, when I call them clinics, I call them really more taking care of different patient groups. We're very creative because, you don't even see them on the list, things that I've started over the years, or that we started. It was actually groups of people that started. So I put leadership on here because really, we used to say this all the time, if it has anything to do with medications, we, pharmacists, we need to own it. We need to at least be at the table. We need to be part of this, help with the solution, get ideas for the solution. So even just going and talking to the physicians and saying, are there medication areas where, what are you don't even have to offer the service, but just finding and listening to them, where areas that they would need help with medications. Because sometimes you don't give them the answer right away. You just listen and you think about it for a little bit, and you do a little bit of research before you come back again. So collaborating with the healthcare professionals, it's really, really, what's going to make all of this work is collaborating with all of them and working together as a team. And all you have to do is find one in the group, in the physician group, or one in the community to start working with, and the word gets around. I have a brother that is a physician, and when he's a specialist in his community, it's not like he opened up his doors and everybody started sending him patients. What he had to do was he had to reach out and visit all the people that were going to refer to him. He had to go to all their activities and all their events and start just working it. He had to let them know what he can do. So the next time they have one of those patients come in, they'd send it to him. And then, he would follow up and take back and do all the communication like you would expect a good practice to have, and then they start sending them more. So this is the same type of thing, getting these clinical services up and going. And I'm mentioning here a little bit about putting an indication on a prescription label. That's a good conversation, something that, you can talk to the physicians about, how can we work on this? They may not even think it's a problem. They may not think it's a problem. So if you need more information, I can send you, because I think there's a lot of physicians that would really like to have this on there. But you just plant the seed, because there's going to be a physician that's going to want to do it. And if they say no, you don't get frustrated, because somebody will say yes. They always do. And I wanted to talk a little bit here about, we already know this for chronic diseases. This is our bread and butter, and that's why I kind of push this hard, because chronic diseases, this is our bread and butter. This is when you have people on multiple medications. This is what we sort out. This is what we can fix. This is what we can optimize. And there's just a lot of opportunities for us. There's a lot of data out there now to really improve patients, to be able to help them take their medications correctly and safely, and just avoid being in the hospital and connecting to them. So you can tell this is a little article from Synchronous. There's plenty of data out there. We've had lots of pilots, and there's data coming in from all these pilots too, that show that care transitions, which I know that Cindy mentioned earlier, when patients move from one healthcare setting, and this is where we can also have a big role. Sorting all this out is very time consuming. I remember we had, even where I was working, we'd have to put somebody on just this group of folks, because there's so much coordination between their caregivers, where they're going, the hospital, but they were all physically, these are a lot of work to clean up these profiles. But if you reach out and go visit the hospitals and work on those relationships there, that's how you kind of fix these issues, and how can we communicate better. So there's great opportunities to reach out and in your own community and work on these. Let me see. The other area that I do, and I just put this on here because there's other people that take care of the patients, and sort of probably the easiest way to do this is anything that is going to be helping the patients. What happens is a lot of holes in the care now. Holes meaning, there's nobody taking care of a particular thing. So let's say, for instance, a patient came in and their health insurance didn't cover something. For the most part, pharmacists are good to try to help get covered, but those are very time-consuming to fix. Let's say their health insurance, they were right in between health insurance and they didn't have any. Well, where are we going to send them? Or if they get stuck on you hear a situation and they have a setting at home, how do we plug them into a different system? Are there social workers? Are there other services out there that you can utilize? And it's almost like you have to build a network, or at least reach out and know who to call to help them, to sort of be the connector maybe, and connect them to the right services, and then, be able to follow up. You're going to see in the next month, or if you don't have a system to follow up to make sure they got taken care of. Okay. Really what this is, and when we're in a closed setting, that's what we end up doing, coordinating a lot of that. We have to coordinate with the outside, and there needs to be somebody doing it. Sometimes it's somebody's job. Sometimes nobody has that job. So I'm just encouraging us, the pharmacy, and I'm not saying necessarily pharmacist, but pharmacy, to take that role until you find the right person that should be doing that, because the patients otherwise will fall through the cracks. And that's the last thing we want to happen, especially if they don't have anybody to help them. It's really tough to watch. So we need champions. And all of you on the call, I know, are champions. And then I put down here this medication management works, and the reason why, you can tell I'm getting ready for the next slide here, it does work. We do have data to show that it does work, and it makes a difference. And I put some of the data because it's kind of really great to see it. 54% of patients, and there were some pilot groups that did this, and 12% of the patients identified as out of control, came under control, using these standardized measures. So anyway, that's a good number there. And then also adverse drug events and other events that caused patients harm by almost 50% between the years that they were doing the measuring. So those are really a difference, and those are the numbers that we're trying to get out right now so that people are aware of all of that. And then, so I wanted to talk about some of there's a lot of challenges. And if I was looking at you in person out in the audience right now, I would probably see in your eyes, you're thinking, this is not possible, we've been here before, and these are really challenges. And I agree that they are, but they're not insurmountable. They're not at all. Some of this requires change. There's a lot of technology out there now. There's a lot of resources. There's just a lot of things to do, but we have to do things different, and it's going to be something that's out of our comfort zone. So that's why I'm kind of encouraging right now. I'm encouraging folks to start making some of those changes in here. We know the financial incentives aren't aligned correctly, but those are being worked on right now, and they will be changing. And the thing is that we can't just start once they get aligned. There's a lot that we can do. Some the financial incentives are actually, we can work on the area where we can get financially reimbursed for these things. There's a lot of value added. It also takes cultural acceptance, and the reason why I say that is I know when I go talk to physicians, some physicians, they haven't worked with pharmacists yet, and they go, we didn't even know you did that. And then we work with other physicians, and they're like, oh yeah, we love pharmacists. So there's still quite a few people that don't even realize what pharmacists can do yet. And the only way they're going to know is if we go out and tell them, but not and communicate with them, and they get to know us over time. There's one of the other challenges that we have is our information technology systems aren't connected to the physicians, like in electronic health record systems. These are all things that are being worked on. And so we have to plant a lot of seeds. And what I encourage the pharmacists to do is to reach out, or pharmacies to do, is to reach out to their main physician groups and find out which kind of electronic health record system they have. And once they find that out, know your system. Ask your vendor, is this something that you're planning to build? There's standards that are developed for all of this. And I know that Cindy would be happy to connect people. I'd be happy to connect people to the right folks to be able to make those connections happen, those electronic connections. So anyway, we have to start somewhere, and those of you that are on the call, you wouldn't be here if you weren't interested in starting something. So that's an easy thing, too, to do, just to even go check and find out what electronic health record system the top 2 physician groups that you're working with have, and then also find out yours and ask your vendor if they're planning to build that connection to the electronic health record system. And then this is one to talk about. For those of you that are in Virginia, you'll notice you're listed first there. I put you first. That there's going to be in 2017 a new model for the Part D. It's called Enhanced NTM model. And what they're doing is for the standalone PDPs, the prescription drug plans, they're going to be trying to find creative ways to integrate the pharmacist into the medication management workflows. So these are great opportunities for us. The plans are going to be given prospective payments, and so there's a lot of work on this. Kind of pay attention to what's going on right now. It's not going to be until 2017. But if you're not doing NTM now, this is something you want to start getting involved with and start that program at your pharmacy if you're not already doing it, because it's only going to be expanding. So pay attention to these topics. There's a lot coming down the pipeline on this. And that's, for the most part, it potentially is new money for you. I just wanted to also mention, too, that there's more change underway. As you see these new care delivery models coming down the pipeline, you'll notice that they're going to be measuring things differently. The focus is going to be on value, accountability, and team-based care. So you'll see these metrics, what they're measuring, is going to be different. It's not just measuring on a lab value. It's going to be, they're going to be measuring different. And they're also going to look and identify gaps in care. So these are areas where you see things not being done. We need to say something, and we need to find out how to fill that gap until there's a role for that. And to kind of give you an example, I used to work, and we'd have respiratory therapy, and I could send them over there, and they can actually do all the teaching of the inhaler, because I had a great respiratory therapy department. I didn't need to do it. But other places where we didn't have that, guess what? Our pharmacy team, all our pharmacists, we did all the education on how to use inhalers, and we did a lot of that. So depending on what services are in your area, that you have to fill the gaps. And then I'm watching here. Let me see. One more. And then I'm going to kind of keep, okay. I just wanted to mention, too, that drugs, we have the famous quote because it's a Surgeon General, that drugs don't work in patients that take them. And my point on this slide, what I wanted to do is that patients, this is on the lesson learned section of this slide, that they don't always fully understand their chronic health conditions about not taking it. Just like I talked to you earlier, they come in, they have a lot of questions about their disease, but they don't always ask them, and they don't want to ask others about it because they're kind of shy about it. And in general, people don't want to burden others with their medical issues. They want to kind of tough it out. They want to manage their own conditions, and they want to be in charge of their health. So this is like it's important to have a whole healthcare team, because you're not going to see the whole picture all the time. And then the last thing, what I wanted to do is I wanted to show you, this is the technology that has arrived. It's here now. You're going to see more and more about it. And so pay attention to it. It's called Connected Health, Smart Medication Monitoring. And I'm just going to kind of give you an idea. So I talked about inhalers. They now have little chips in there, and you do the inhaler, and you can they can tell, it's all connected health. They'd be able to tell, like, how much of a dose the person got, if they shot it in the air, if they put it in their mouth, because it measures all of that, the temperature, expiration date, everything. It's all really high-tech. Everything's high-tech. And it's here now, but what we haven't done is worked it into our processes yet. So this is a great area for pharmacists to get involved in. It's also called exception management. In other words, everything goes fine until you see, like, whoops, it looks like they missed their doses today. That's exception management. So anyway, you see this is in patches. It's in the pill boxes too. And then it's all with smartphones. And I'll just tell you, there's a difference between asynchronous and synchronous health communication. So normally what we're used to is, I don't think this is all working. Oh yeah, normally like the patient will contact the doctor's office as a nurse, and then the nurse calls the pharmacy, and then, the nurse asks the physician. You see, this is how the normal communication might go. But in this other type of asynchronous communication, it can be done all at once. So this is why they call it exception-based. And you can manage a lot more patients. So you're going to see this. It's actually already happening in several different places, and you're going to see more and more of this. So I've been encouraging pharmacists to get involved. This is like such a cool area to be. So finally, I love this quote, and because it's from Gandhi, and it says basically what the bottom line is it's the action, not the fruit of the action. It may not be in your power, it may not be your time, and that there'll be any fruit, but that doesn't mean you stop doing the right thing. You may never know what results come from your action, but if you do nothing, there's not going to be any result. And I listed down here several different action items that I hope you can kind of take something away from. So these are, and I've kind of talked about these the whole time. One of them is building the relationship with the local hospital and your providers. I talked a little bit about healthcare teams, but also in your pharmacy. This is an area where you might want to think about the different types of people that you have on staff. You want someone with a business background, IT background, someone that's a PR person, public relations. You're going to need that function that can, and finance, doing all the business plan, doing all of that. Either and clinical skills, obviously. Those are the types of skill sets that you want to have to be successful. And then I listed some things down about your business plan, and then also to pay attention to all these areas that are coming down the pipeline, a lot of them related to IT. And then also, if you have students, put the students in charge of some of this stuff. Students love doing these activities, and they can work on any of these areas too. And let's create the healthiest nation in one generation. That's kind of what we've been pushing. So anyway, I kind of probably went over, but that's it, Cindy.
Okay, if you want to pass the bottle back to me, Admiral Schweitzer, that would be great. I want to thank everyone for attending. Obviously, due to the time, questions are important, and I would like you all to please email or chat your questions, and I promise to get answers back to you. As a quick wrap-up and sort of a kickoff for this first webinar, the next 4 sessions will include the 5 pillars of medication safety, and we will focus on hypoglycemia, anticoagulation, and opioid use. There will be practical applications to this, and I'm hoping that you all will attend those next sessions. CE will also be provided for the pharmacist. As parting comments, I would like to once again thank everyone for participating. I also would like to thank Rear Admiral Schweitzer for her wonderful presentation. I hope each of you will take the challenge that she has placed before each of us today. Push the envelope, think outside the box, challenge your colleagues, and know that your time and efforts do make a difference in the healthcare arena. I'd also like to thank you for participating. Thanks to BPHA again. The link on the bottom of this slide, Pharmacist, you will need to go to that link and fill out the survey in order to obtain your CE credit. We will also, because I know there were some people that were not able to get on to the webinar but were able to hear on the phone, there will be a posting of the slides and a recording of the webinar. So I would like you to encourage your colleagues that might either be at the counters or in the hospitals or in the long-term care or nursing home facilities. The webinar will be posted on both the Virginia Pharmacists Association webpage as well as the VHQC community virtual page. So please, if anyone has any additional questions, please either email me or put them in chat and I will follow up with them. Rear Admiral Schweitzer, I would like to thank you again for this awesome, inspiring presentation. Thanks, everybody.
This concludes today's teleconference. You may now disconnect.